So we are going to have an overview of the urinary system, and the urinary system is divided into the upper urinary tract and the lower urinary tract. The upper urinary tract and the lower urinary tract. The upper urinary tract is made up of the adrenal glands, the kidneys, and the ureters. The adrenal glands, the kidneys, and the ureters, and it is predominantly located in the abdomen. The lower urinary tract is made up of the urinary bladder and the urethra. The urinary bladder and the urethra. So the adrenal glands or suprarenal glands, because they are on the superior pole of the kidneys, the kidneys themselves and the ureters form the upper urinary tract. The urinary bladder and the urethra form the lower urinary tract. The kidneys begin to develop early in the 4th week of intrauterine life. When you remember our embryology, organs begin to develop between week 3 up to week 8. And that is the period of organogenesis in the first trimester of gestation. And when you look at early in for the 4th week, it fits within the period of organogenesis. The first kidney to develop early in the 4th week is made up of tubes. And those tubes are located in the neck region or cervical region. So early in the 4th week, a primitive kidney known as the pronephros, made up of tubes in the cervical or neck region, appears. This kidney with these tubules is non-functional. It breaks down and disappears, and it's known as the pronephros. Late in the 4th week, another kidney system develops, made up of a duct known as a mesonephric duct and connected to tubules known as mesonephric tubules. This mesonephric duct is the same duct which contributes. So after the pronephros, we go late in the 4th week and we see the mesonephros. The mesonephros also degenerates, but part of the mesonephric duct remains. It degenerates, but part of the mesonephric duct remains. Then early in the 5th week, another kidney system develops. That kidney system which develops is located, number one, it's located in the pelvic region. Remember, early in the 4th week, the pronephros was in the neck region. Late in the 4th week, the mesonephros was in the upper thoracic and lumbar region. And now, early in the 5th week, a third kidney system develops known as the metanephros, and it is in the pelvic region. And this metanephros is the one which is going to form our permanent kidney. So your kidney, in the 5th week, it was in the pelvic region, known as the metanephros. Now, this metanephros, you remember I said that the mesonephros, part of its duct remains. So part of the mesonephric duct which remains after the mesonephros has degenerated protrudes or buds to give us a bud known as the uretic bud. And then this uretic bud gets surrounded by intermediate mesoderm tissue, which is known as the metanephric mesenchyme. So it means that this permanent kidney has a part of the mesonephric duct known as the uretic bud, and cells from the intermediate mesoderm known as the metanephric blastema. They are the ones which are going to form our permanent kidney, the metanephros, which develops early in the 5th week of intrauterine life. This uretic bud, which is a protrusion of the mesonephric duct is the one which is going to form the conducting system of the kidneys. That is the ureter, the renal pelvis, the calyces, and the collecting tubules. And this metanephric mesenchyme, which are the cells from the intermediate mesoderm, are the ones which are going to form the urine-forming machinery, which is the Bowman's capsule, the proximal convoluted tubule, the distal convoluted tubule, and the loop of Henle. So when you look at illustrations, the pronephros occurs in the neck region and breaks down. In the upper thoracic and upper lumbar, another kidney system develops known as the mesonephros late in the fourth week. It has a mesonephric duct joined by mesonephric tubules. It also breaks down, but part of it remains in the pelvic region, and early in the fifth week, this remnant of the mesonephric duct buds off to form what we call the uretic bud. This uretic bud gets surrounded by cells from intermediate mesoderm known as the metanephric blastema, such that our permanent kidney in the metanephros has a contribution from the mesonephric duct, the uretic bud, and the metanephric blastema. This uretic bud is the one going to form minor calyces, major calyces, renal pelvis, and the ureter, whereas these cells surrounding it are the ones which are going to form the proximal convoluted tubule, the Bowman's capsule, the loop of Henle, and the distal convoluted tubule. More illustrations are showing us the pronephros breaking down, the mesonephros coming in, and after that, the pronephros breaks down early in the fourth week. Then we'll have our mesonephros late in the fourth week with the mesonephric duct and then the mesonephric tubules. It also breaks down, and then part of it which remains in the pelvic region gives off a bud known as the uretic bud, which gets surrounded by the metanephric blastema, which are the cells of intermediate mesoderm. The uretic bud is the one which forms the minor, major calyces, renal pelvis, and the ureters, and then the metanephric cells are the ones which are going to form the Bowman's capsule, proximal convoluted tubule, loop of Henle, and distal convoluted tubule. And this kidney system in the pelvis is what we call the metanephros. It's the one which develops into our permanent kidneys. And as you grow, it begins ascending to the abdomen. Because of the changes of the size of the body and the proportion of the abdomen, it will ascend up until it reaches its final position at the posterior abdominal wall. So originally your kidneys are in the permanent kidneys, the metanephros is in the pelvis, but it will ascend. So that is a brief of how the embryology of the kidneys come about. So we have talked about the development of the kidneys and the ureters, that's the upper respiratory tract. What about the lower respiratory tract, which is the urinary bladder and the urethra? During the same period, when the kidneys are forming, the bladder is also forming, specifically between week 4 to week 7. How does it form? And I want you to observe. How does it form? And I want you to observe. The terminal end of the digestive system is known as the cloaca. The terminal end of the digestive system is known as the cloaca. The terminal sac. And I've indicated it in many. This terminal sac is known as the cloaca. So the contents of the digestive system are going to come and pour into this cloaca. Contents of the digestive system, you see, they come and they pour into this terminal sac known as the cloaca. So this cloaca begins to be separated by a septum. This septum is the one we call the urogenital septum. So the urogenital septum divides the cloaca into two parts. The anterior part is known as the urogenital sinus, and the posterior part is known as the anorectal canal. So this terminal sac, the cloaca of the digestive system, gets separated by a septum known as the urorectal septum. into an anterior urogenital sinus and a posterior anorectal canal. The mesonephric duct and the metanephros will now go with the anterior urogenital sinus, such that they will not be connected to the posterior anorectal canal, but during the separation, during the formation of this septum, the separation takes these to the mesonephric duct and our kidneys, which are the metanephros. For them, they go with the anterior urogenital sinus, not with the posterior anorectal canal. The urorectal septum will continue to divide and completely split the cloaca into the anterior urogenital sinus and the posterior anorectal canal. The anterior urogenital sinus is going to form our urinary bladder and the urethra, and the posterior anorectal canal is going to form the rectum and anal canal. If the urorectal septum does not form completely, you're going to have communications between the urinary bladder and the rectum, which is what we call the fistula. So in simple terms, I've simplified it that this cloaca, the terminal sac of the digestive system, is the one which gets split into two by the urorectal septum into the urogenital sinus and anorectal canal, and the urorectal septum continues to separate them completely, such that the anterior portion, the urogenital sinus, is going to form the urethra and the urinary bladder, and the posterior anorectal canal is going to form the rectum and the anal canal. And our permanent kidney, which we have seen developing, the metanephros, will maintain its connection with the anterior portion, which is the urogenital sinus, not the posterior portion. That is why the ureters drain into the urinary bladder, which is derived from this portion known as the urogenital sinus. All these illustrations are showing the same thing. So even when you look at the male pelvis, you have the urinary bladder anteriorly, and then you have the rectum posteriorly. The rectum was developed from the anorectal canal, and the urinary bladder developed from the urogenital sinus. And this is the position where we had our urorectal septum. And you see the ureters connecting to the urinary bladder, not to the rectum. Our kidneys are located on the posterior abdominal wall. The kidneys are located on the posterior abdominal wall, and they are bilateral. We have the right kidney and the left kidney. The right kidney is located in the right lumbar region, and the left kidney is located in the left lumbar region. This is a kidney in sagittal section, and here you can see the kidney in transverse section. Here you see this is a transverse section of the abdomen. You can see a kidney on this side, which is the left kidney, and a kidney on this side, which is the right kidney, in transverse section. This is the vertebral column. Anterior to it, you have the inferior vena cava. If this is the inferior vena cava, this is the right side. If this is the aorta, this is the left side. So this is the left kidney, this is the right kidney. This is the abdominal wall, posterior abdominal wall, because it's a vertebral column and they are bilateral. In sagittal section, this is how it looks like. It's been shaped. The kidney is lined by layers. The kidney is lined by layers which are protective. Are you hearing me?
Yes, sir, we are hearing you well.
Are you hearing me? The first
Yes, sir,
layer
we are hearing you
is
well.
the renal capsule. Is in contact with the surface of the kidney. On top of it, we have the perirenal fat. So the protective layers are four. From south, the renal capsule, the perirenal fat, the renal fascia, and the pararenal fat are the ones which protect the kidney and absorb shock. And even when you look at them in transverse section, this is the left kidney in transverse section. Remember, the left kidney is near the aorta, and the right kidney is near the inferior vena cava. Never forget that. So this is in transverse section. You can see the renal capsule, the perirenal fat, the renal fascia, and the renal pararenal fat. These are the layers which are the protective layers around the kidneys, and they absorb shock. The renal capsule, the perirenal fat, the renal fascia, and the pararenal fat layer on both kidneys. The internal structure of the kidneys is very important, because even when you're doing ultrasound, the internal structure, you see it clearly. The outer layer is the cortex from your primary school knowledge, and the inner layer is the medulla. Is there anyone who doesn't know that? Silence means that you all know. So when you make a cross section through the kidneys, the outer layer is the cortex and the inner layer is the medulla. And on ultrasound and imaging modalities, it is very clear. However, you see the cortex sends columns deep into the medulla to divide the medulla into, what are these members? The medulla is divided into what?
Pyramids.
Medullary pyramids. The apices of the medullary pyramids are facing towards the hilum, and the bases are facing towards the cortex. So the cortex sends deep into the medulla columns to separate, to split it into what we call medullary pyramids. These cortical columns are the ones which are known as columns of Batten. On ultrasound, they call these columns of Batten. B-E-R-T-I-N, columns of Batten. So whenever you're making an ultrasound scan of the kidneys, identify the cortex, identify the medulla, identify the columns of Batten. Then the pyramids connect to minor calyces. You remember the uretic bud? The uretic bud derivatives begin from the minor calyces. Then the minor calyces join to form the major calyces. And the major calyces join to form what? What do they form?
The pelvis.
The renal pelvis. And the renal pelvis is going to form the what?
The ureter.
The ureter. Why? And this region where you have these cavities, the minor calyces, the major calyces, there is some fat which is there. And then you'll see that it looks different on ultrasound. So the internal structure, cortex, columns of Batten, medullary pyramids, minor calyces, major calyces, pelvis, ureters. Even when you're scanning, you can see those. Can I show you an example? This is an example. Okay. This is the cortex. This is the cortex of the kidney. These are the columns of Batten. These are the columns of Batten. Those ones. And in between them, you have the medullary pyramids. And this light region where you have fat, that is where you have the major and minor calyces. And when you're doing your ultrasound, they tell you why this is dark, why this is bright, why this is intermediate. Don't worry about it. But the structure is outlined. The cortex, the columns of Batten, in between them you have the medullary pyramids, and this is the region which has the minor, major calyces. It's so bright because in between them you can see there is some fat there. So this internal structure of the kidney is very, very important, even in the making of diagnosis of pathologies. Who can tell me what is the blood supply to the kidneys? Blood supply. How do the kidneys receive oxygenated blood?
It's through the renal artery.
The renal artery. And the renal artery is a branch of which artery?
From abdominal aorta.
So the abdominal aorta gives off two renal arteries. One going to the left kidney, that's the left renal artery, and the other one going to the right kidney, that is the right renal artery. I'm going to look at the differences between the two arteries. Yes, both of them are renal, but they have some differences. Here we are seeing the renal artery entering the hilum of the, this is the hilum of the kidney, the point of entrance and exit of blood vessels and structures. So the renal artery enters the hilum of the kidney. And I'm going to show you that the renal artery supplies other structures, but let us begin with this and we shall build on that. So the renal artery reaches the hilum of the kidneys. I want you to follow. It branches into what we call segmental arteries. It branches into what we call segmental arteries. The segmental arteries, when they reach the columns of Barton, they divide into what we call interlobar arteries. Have you seen these two? Renal artery, segmental artery, interlobar arteries. The interlobar arteries, when they reach the base of the pyramid, they form arcuate arteries. These are arcuate arteries. And the arcuate arteries will then form what we call the interlobular arteries. Let's go and look at another illustration. I'll come back and see it properly. The renal artery, the segmental arteries, then we'll have the interlobar arteries. These are interlobar arteries in the periphery of the columns of Barton. Then, when the interlobar arteries reach the base of the pyramid, they form arcuate arteries. These arcuate arteries are going to form interlobular arteries, and the interlobular arteries are going to give us afferent arterioles, which are going to supply the glomerulus. So whenever they are talking about the blood supply of the kidneys, do not end at the renal artery. It sits the renal artery, a branch of the abdominal aorta. When it reaches the hilum, it divides into segmental. The segmental divides into interlobar. The interlobar divide to form, branch to form the arcuate, and the arcuate form the interlobular, and the interlobular give us afferent arterioles, which afferent arterioles are going to go and supply the glomerulus in the renal corpuscle, where glomerular filtration takes place. And the veins follow the arteries. The efferent arterioles from the glomerulus drain into the interlobular veins. The interlobular veins drain into the arcuate veins. The arcuate veins drain into the interlobar veins. The interlobar veins drain into the segmental veins, and the segmental veins drain into the renal veins. So you begin from the other side, because that blood is going to be moving in counter current. So what is this, members? Who can tell me what this is? What is this?
Renal cortex.
The
And what is
the renal
this?
cortex.
What are these ones?
Column of Barton.
And what are these ones?
Renal pyramids. Medullary
And
pyramids.
this, what does this region contain?
The fats
Blood
and
vessels
the
and-
blood supply.
The what?
Fats
tissues
and blood vessels.
And what? Fat, blood vessels, what else?
Nerves.
And what else? There is a lot here. When you look at these illustrations, there are blood
Major
vessels
renal
calyces.
calyx.
and the
Major
calyces.
and
Yes.
minor calyces.
So it is so bright because there is a lot here. There is a lot here. But the calyces are going to become profound in conditions that I will tell you. You're going to look at the structure of the nephron, and then you study it well. However, the nephron begins at the renal corpuscle. What is a renal corpuscle? A renal corpuscle is the machinery of the kidney which forms the glomerular filtrate, which is going to be converted into urine. A renal corpuscle is made up of a component of blood vessels and a component of the nephron. So on the other side, you have capillaries, which form the glomerulus, and on this side, you have an enlarged portion of the tube known as the Bowman's capsule. So the Bowman's capsule let's see. The Bowman's capsule, which is in this enlarged portion of the tube, plus this tuft of capillaries, which is the glomerulus, together they form what we call a renal corpuscle. And because of the different pressures of fluid within the Bowman's capsule and the renal corpuscle, a renal filtrate is formed, which passes through the nephron and is converted into urine, which is drained into the collecting ducts. So whenever they talk about a renal corpuscle, they're talking about the glomerulus, which is a tuft of capillaries, and this enlarged part of the tube known as the Bowman's capsule. These two components form what we call the renal corpuscle. So you're going to look at the structure of the nephron and how urine is formed within the nephron, because that is new knowledge. What are the relations of the kidneys? When you're looking at the relations of the kidneys, we look at the anterior relations, but you have to be specific for the right kidney and for the left kidney. And even the posterior relations, you have to be specific for the right kidney and for the left kidney. We separate the two kidneys. So anterior to the right kidney, we have the adrenal gland. Now, the adrenal gland of the right kidney slightly comes anteriorly. Slightly comes anterior. So that is why it is indicated there. The liver, and that is the right liver, covers the right kidney, specifically the superior pole. The second part of the duodenum covers the medial aspect of the right kidney, the right colic flexure, and the jejunum. These structures lie anterior to the right kidney. Let us give an example. This is the right kidney. You can see the second part of the duodenum. So the anterior relations of the right kidneys, superior will have the suprarenal gland and the right lobe of the liver, covering the superior aspect. Medial will have the second part of the duodenum. Inferior here will have the right colic flexure. The right colic flexure is when the ascending colon is bending to form the transverse. It lies anterior to the right kidney. And this is the right kidney. It shows us that this anterior surface is covered by the suprarenal gland. This is covered by the liver. This is covered by the colic flexure. This is covered by the second part of the duodenum. And here it is covered by the jejunum. These are the relations of the anterior aspect of the right kidney. The anterior aspect of the left kidney, it is also, we have the suprarenal gland, we have the fundus of the stomach. These are the structures anterior to these portions of the left kidney. Then we have the pancreas, and then the spleen covers that anterior surface. The jejunum covers this, and then the colon, that is the left colic flexure. These are the structures which lie anterior to the left kidney, and these are the structures which lie anterior to the right kidneys. Posterior to both the right and left kidneys, we have the diaphragm. It curves and goes posteriorly. We also have these two muscles, psoas major and quadratus lumborum. They are common factors. The diaphragm, the psoas major, the quadratus lumborum are posterior to both the right and the left kidneys. Rib 11 and rib 12 are still posterior to both the right and the left kidneys. So in general, the posterior relations of the two kidneys are similar, whereas the anterior relations differ. And relations of the kidneys are very, very important. Rib 11 and rib 12, both of them lie posterior to the right and the left kidney. The left kidney is slightly higher and the right kidney is slightly lower because the right lobe of the liver is bigger. It compresses it and it descends. And these nerves, the subcostal nerve T12, iliohypogastric and ilioinguinal L1, they all pass posterior to the kidney. So you see the posterior relations of the right kidney and the left kidney are principally the same. Just that the right kidney is slightly lower because it is compressed by the right lobe of the liver. So this is the transverse section of the right kidney. You can see the psoas major and the quadratus lumborum muscles are posterior to it. And we saw that psoas major and quadratus lumborum muscles are posterior to both kidneys. And you can see those muscles in transverse section. Psoas major, which is attached to the vertebral column, and then the quadratus lumborum, which is there. These muscles lie posterior to the kidneys. And when you look at a sonographic image, we have our right kidney here. You're going to see the vertebral column around here. This is the psoas major. This is the quadratus lumborum. Psoas major. So we are having an example of the right kidney, and we are looking at this because the posterior relations are the same for both the right and the left, with the exception of the anterior relations. This is the kidney, the right kidney, because this is our inferior vena cava. This is the vertebral column, and you see the psoas major muscle attached to the vertebral column, and then the quadratus lumborum. They are kind of forming an L, and anterior to them is our kidney. So similarly, you're having this. The vertebral column is here. Don't worry about the appearance. This one they will teach you when you do ultrasound physics. But our psoas muscle is there, our quadratus lumborum muscle is there, and our right kidney is there. This is the inferior vena cava. Aren't you seeing that these things look the same? Even when you look at the gross anatomy image and then the sonographic image, there's a similarity. Aren't you seeing that?
Yes.
And you're seeing anterior to the kidney. These are the posterior structures, and then this is the liver, which is anterior to it. So when you appreciate the relations and understand them, it's going to be easy for you to appreciate that sonographic image or CT image or MRI image. And this is shown in transverse plane. Still, this is another transverse plane. This is the psoas major. This is the vertebral column. This is the psoas major. This is the quadratus lumborum. Psoas major, quadratus lumborum. This is our right kidney, and anterior to it is the liver. This is the transverse section. Anterior to it is the liver. Then posterior to it psoas major, quadratus lumborum. In between them is our right kidney. I'm just trying to show you that the anatomy you're studying is relevant when it comes to ultrasound. The renal arteries, we saw them. They are branches of the abdominal aorta at the level lumbar vertebra 1. Now I want you to look at this critically. This is our right kidney, and this is our left kidney. The right kidney is slightly lower because of the big right lobe of the liver, meaning that the right renal artery is given off at a slightly lower level than the left renal artery. Because, sorry, because of the big right lobe of the liver, it kind of presses the right kidney to descend slightly lower than the left kidney. That is why the right renal artery is given off at a slightly lower level than the left renal artery. But both of them are branches of the abdominal aorta at level approximately L1. What are we seeing? We are seeing this inferior vena cava on the right and the aorta on the left. When the right renal artery is given off, it passes posterior to the IVC and then it goes to enter the right kidney. So on its way to the right kidney, the right renal artery passes posterior to the inferior vena cava, and that makes it longer than the left. It passes posterior to the inferior vena cava and also posterior to the right renal vein, and then it will enter the hilum of the right kidney. Whereas the left renal artery is given off at a slightly higher level than the right renal artery, but for it passes only posterior to the left renal vein. So the left renal artery, number one, is given off at a slightly higher level because the left kidney is higher than the right kidney. Number two, it is shorter than the right renal artery. Number three, it only passes posterior to the left renal vein and enters the left kidney. So this left renal artery, given off at a slightly higher level, it is shorter, it only passes posterior to the left renal vein. Right renal artery, given off at a slightly lower level, it is longer, it passes posterior to both the IVC and the right renal vein. Then the renal veins. The renal veins will have the right renal vein and the left renal vein. The right renal vein drains into the inferior vena cava, still at a level slightly lower than the left renal vein because of the position of the right kidney. It is shorter than the left renal vein. On the other hand, the left renal vein moves anterior to the left renal artery. It passes posterior to the superior mesenteric artery and then joins the inferior vena cava at a slightly higher level than that of the right renal vein. So in this position, the left renal vein is passing anterior. The left renal vein is passing posterior, not anterior. So at this position, the left renal vein is passing posterior to the superior mesenteric vein and anterior to the abdominal aorta. Are you seeing that? The left renal vein is passing posterior to the superior mesenteric vein and anterior to the aorta. Are you seeing that?
Yes.
Therefore, it is in between the aorta posteriorly and the superior mesenteric vein anterior. It is sandwiched in between those. And this is what we call the pincer effect, compression of the left renal vein as it is passing between the aorta posteriorly and the superior vena cava anteriorly. And this happens only to the left renal vein. So these gross differences must be appreciated, much as we know that the renal veins drain and supply the kidneys. Now, what other branches are given off by the renal arteries? What other branches are given off by the renal arteries? What other branches are given off by the renal arteries. Because I said that renal arteries not only supply they not only supply the kidneys, but they also supply the structures. Now, the renal artery gives off a branch to the suprarenal gland, that is the suprarenal artery, and then a branch to the upper aspect of the ureter, and then it will enter the hilum of the kidneys. So in its way, it supplies the suprarenal gland, the upper portion of the ureter, and then it will enter to supply the kidneys. So we not only talk about it as a supply to the kidneys, but it gives off a branch to the suprarenal gland, a branch to the ureters, and then it will enter the hilum of the kidneys on both sides. Whereas the renal veins, the left renal vein receives blood from the suprarenal gland and the left gonadal artery, but the right renal vein only receives blood from the suprarenal gland. So the tributaries of the left renal vein will have the suprarenal vein, and then the gonadal vein, and then some veins coming from the upper part of the ureters. Whereas on the right, we have the tributaries from the suprarenal glands and then from the ureters, because the right renal vein does not receive the gonadal artery. The gonadal artery on the right drains into the IVC. So it is very, very important for us to appreciate the blood supply of the kidneys and its venous drainage in detail, other than saying renal artery and renal vein and ending there. And I may ask the differences between the right renal vein and the left renal vein, the differences between the right renal artery and the left renal artery. Talk about the branches, the tributaries, the structure, its course, its relations, so that you appreciate it very well. The ureters, on average, in an adult, 25 centimeters long. They propel urine from the kidneys down to the urinary bladder, and now the ureters are narrowed at 3 positions. We shall look at those positions where they are narrowed. But to begin with the histology, the inner lining of the ureters, are you hearing me?
Yes, we can hear you.
The inner lining of the ureter is made up of a transitional epithelium, and I believe you did epithelial tissue in cells and tissues. The inner lining is made up of a transitional epithelium. Then that when we make a cross section through the wall of the ureter, the inner lining is made up of a transitional epithelium sitting on a basement membrane known as the lamina propria. It's mainly made up of collagen. And then it's made up of a smooth muscle, that's the muscular layer. This is the layer which contracts as the ureter is propelling the urine. And then the outer layer is the adventitia. So we are looking at the inner lining, which is the transitional epithelium. The transitional epithelium, which is sitting on a basement membrane, the lamina propria. And then we'll have the muscularis layer, which is made up of the inner longitudinal and the outer sacula, and then the outer layer, which is the adventitia. Are we together?
Yes.
Yes, sir.
The inner layer is made up of the transitional epithelium, then the basement membrane, which is the lamina propria. All of these form the mucosa. Then the muscularis layer made up of the inner longitudinal and the outer sacula, and the outer layer, which is the adventitia. That's the histology of the ureters. The anterior relations of the ureters. The proximal part will have the second part of the duodenum. Then the middle portion will have these blood vessels crossing anterior to the ureters. The right colic, and the ileocolic. You remember our GIT. The ileocolic and the right colic supplying the ascending colon in the right lumbar. Then the gonadal vessels. So these branches of the superior mesenteric, the right colic, the ileocolic, and then the gonadal vessel, which is the testicular ovarian on the right, they pass anterior to the ureter. Then this is the mesentery. This mesentery of the small intestines crosses anterior to them. So these are the anterior regions of the right ureter. It lies posterior to them. That's why the ureter is on the posterior abdominal wall. Then the left, we have the left gonadal vessel, the left colic, a branch of the inferior mesenteric, and the sigmoid branches. These are supplying the descending colon and the sigmoid colon, and then the sigmoid mesocolon, that is the mesentery of the sigmoid colon. These lie anterior to the left ureters. You know, imaging is more about structures and their relations, because when you're scanning that structure of interest, you see those blood vessels and structures crossing anterior to them. Posterior to the right ureter and left ureter, you are going to see this muscle called quadratus lumborum. Quadratus lumborum. Psoas, not quadratus, psoas muscle. This is the psoas muscle, not quadratus, psoas muscle. So this muscle psoas lies posterior to the right and the left ureters. So the posterior regions are the same. The blood supply to the ureters, we have the upper portion is receiving blood supply from the renal artery. The middle portion receives blood supply from the gonadal arteries, testicular or ovarian, depending on the sex. And the inferior portion is receiving blood supply from the superior vesical artery, which is a blood vessel to the urinary bladder. Upper portion, a branch from the renal artery. Middle portion, a branch from the gonadal arteries. Lower portion, a branch from the superior vesicle, which is coming from the internal iliac. However, those are the major vessels which supply the ureter predominantly. But you might have minor branches from the aorta and the other vessels of the pelvis. The ureter is narrowed in 3 positions. The ureter is narrowed in 3 positions, and these narrowings can lead to kidney stones lodging there. And when a kidney stone lodges in a portion of the ureter, it blocks the flow of urine. When urine flow is blocked, we are going to see the major calyces widening, because the urine which is entering them is not being drained because of a blockage somewhere. So on ultrasound and on imaging modalities, you're going to see the calyces widening, accumulating with urine, a condition known as hydronephrosis. Why? Because there is a blockage somewhere along the flow of the urinary tract. Mainly, it can be a kidney stone which lodges there. It can be a mass which lodges there. So it can be a pregnant woman. As the fetus grows, the fetus can compress the ureters and kind of narrow them such that you have some hydronephrosis in the kidneys. Hydronephrosis is the widening of the calyces and the renal pelvis because of accumulation of urine, and what is causing that is either blockage of the ureters or they are narrowing. So we have the first narrowing is when the renal pelvis is bending to join the ureter. When the renal pelvis is bending to join the ureter, we have the first narrowing or constriction there. And when the ureter is crossing the bifurcation of the common iliac around here, there is a second narrowing here. This is the pelvic brim, the entrance of the pelvis. You see it is passing anterior to the bifurcation of the common iliac. So these common iliac vessels are pulsating, especially the artery, and that pulsation is going to lead to a narrowing there. And the third narrowing is when the ureters are draining into the urinary bladder. That's where you have the third narrowing. The first narrowing at the hilum when the pelvis is bending to join the ureter. The second when it is crossing the common iliac blood vessels at their bifurcation at the pelvic brim. And the third when it is entering into the urinary bladder. And these narrowings, broken tissue can block there, kidney stones can block there, and then it will block the flow of urine. And if urine is blocked, it is going to accumulate in the calyces and they're going to widen out to cause a condition known as hydronephrosis. However, in cases of pregnancy, the developing fetus can also compress this ureter and narrow its lumen, leading also to the temporary hydronephrosis. So the first narrowing at the point where the renal pelvis joins the ureter, the second narrowing when it's crossing the common iliac, and the third narrowing is when it's entering the urinary bladder. So kidney stones can lodge anywhere at those points. And then the urine is going to accumulate here, and these are going to enlarge to cause hydronephrosis. Cancerous tumors can also lead to blockage, and other tissues which are dead tissues which have broken off can also lodge there. The principle is that there is a narrowing and any solid can lodge there and prevent the flow of urine. So here we are seeing our kidney cortex, columns of Barton. Here we are seeing the region of the minor calyces, and then we are seeing a stone here, no renal calculi. You can see this is the renal pelvis bending to continue with the ureter. The renal pelvis bending to continue with the ureter. So the more you retain urine, the more it concentrates and the more it can cause these solid structures known as calculi. That's why you're supposed to take so much water so that you do not have concentrated urine, and you must empty your urinary bladder whenever you sense the urge to urinate, because when you take little water, urine is going to be concentrated and then it is going to crystallize. The sodium chloride and other minerals are going to crystallize to form these stones. And when this stone reaches the first constriction, it can lodge there and block the flow of urine. And you're going to be seeing more of those stones in your clinical practice. The lower urinary tract is made up of the urinary bladder and the urethra. The urethra in females is very, very short than that of the males. This, what plane is this? Is it transverse, sagittal, or coronal?
Sagittal plane.
Is it a male or a female?
A female.
A female.
We can see our abdominal wall. We can see our pubic symphysis, the retropubic space communicating with the extraperitoneal fat, the urinary bladder connected to the urethra, and this part of the urinary bladder connecting to the urethra is the neck of the urinary bladder. We can see the vesicouterine pouch superior to it, the body and fundus of the uterus superior also, then posterior to it you have the cervix and then the vaginal canal. Posterior to the uterus you have the pouch of Douglas, posterior to the pouch of Douglas you have the rectum. The structures in the female pelvis shouldn't confuse you whether they are in sagittal or in transverse. So the relations of the urinary bladder in males and in females differ. Posterior to the urinary bladder in which structures are posterior to the urinary bladder in males? Who can labor?
Seminal vesicles.
Seminal vesicles, what else?
The prostate gland.
The posterior lobe of the prostate, but not necessarily. The prostate is inferior. Apart from seminal vesicles, what else is posterior to the urinary bladder in males?
The rectum.
The rectum, what else apart from the rectum?
Rectovesical space.
The rectovesical pouch. What else? There's a structure which joins the seminal vesicles. It moves superiorly, then posteriorly. There's a structure which comes and joins the seminal vesicles. I talked about it. What is it?
Epididymis.
The epididymis is down here. But the structure which comes posterior to the urinary bladder and joins the seminal vesicles, what is it? The vas deferens, and some of you have forgotten it. The seminal vesicles, the vas deferens, the rectovesical pouch, and the rectum, they are posterior to the urinary bladder in males. And posterior to the urinary bladder in females, we have the vagina and the cervix. Vagina and the cervix. Those are the posterior regions of the urinary bladder in females. Superior to the urinary bladder in females, we have the vesicouterine pouch, the body and fundus of the uterus. These are superior relations. The vesicouterine pouch, the body, and the fundus of the uterus. Inferior to it, you have the urethra. Anterior to it, you have the retropubic space and the pubic symphysis. The relations of the urinary bladder in both males and females are similar generally, but the posterior relations and the superior relations are different. The posterior relations, you have the vas deferens, seminal vesicles, rectovesical pouch, rectum. In the female, we have the vagina, cervix. Superior relations, you have the coils of the intestines above for males. And for females, you have the vesicouterine pouch, the body, and fundus of the uterus. Inferior to the urinary bladder in males. What is inferior to the urinary bladder in males? What is in
Prostatic urethra.
prostatic urethra and the prostatic urethra and what?
And the other lobes of the prostate gland.
And the prostate. The prostatic urethra and the prostate are inferior in males. Superior will have the coils of the intestines. In females, inferior will have the urethra, and then superior will have the vesicouterine pouch and the uterus. And the posterior relations are also indicated, and they are different. So whenever you're talking about the relations of the urinary bladder, you must specify in males and then in females, and you must have good illustrations to demonstrate those relations. Don't just cram them and list them down. Outline them, illustrate them, visualize them, understand them. Cram work is not going to be to help you. That is why I ask you to demonstrate. The urinary bladder, the inner lining is the transitional epithelium lying on a lamina propria. Then it is made up of a smooth muscle known as the decursor muscle with longitudinal and circular fibers. And then it has the outer covering, which is the adventitia. Principally, it is the same histology like that of the wall of the ureters. When you look at the urinary bladder, in sagittal section, it has an apex which is posterior to the pubic symphysis, and this side is the base. So it has an apex, and opposite to it is the base. The base is the one which is lying against the rectum. And then this part which is joined by the urethra, not the urethra. This part which connects to the urethra is the neck. So it has an apex, it has a base, it has a neck. When you look on the inside of the neck, the epithelial lining of the neck is triangular and it forms what we call the trigone. The inner lining of the base is triangular and forms a trigone, and at the upper corners of the trigone, that is where the ureters join the urinary bladder. So this is the apex, this is the base. In coronal section, it will show you its triangular appearance, and then this is the neck of it. And the ureters drain into it at the corners of the trigone. The superior and inferior vesical arteries, branches of the internal iliac, supply blood to the urinary bladder, a superior aspect and an inferior aspect. The detrusor muscle is a smooth muscle. That is why it's supposed to be supplied by the sympathetics and the parasympathetics. The parasympathetics come from the lower spinal cord segments S2, S3, and S4. And the sympathetics come from the sympathetic trunk. So the sympathetics cause the relaxation of the detrusor muscle and the contraction of the internal sphincters so that the bladder can fill. When you look at this urinary bladder, the sympathetics are going to cause the relaxation of the detrusor muscle so that the urinary bladder can expand and fill, and the contraction of these internal sphincters so that urine does not get out. So the sympathetics are going to cause bladder filling. The parasympathetics are going to cause the opposite, contraction of this muscle, the detrusor, and relaxation of the internal sphincters so that the urinary bladder voids. So we are seeing the internal iliac artery giving off the superior vesical artery, supplying the superior aspect of the urinary bladder, and then the inferior vesical artery, supplying the seminal vesicles, the prostate, and the inferior aspect of the urinary bladder. S2, S3, S4 segments of the spinal cord give us parasympathetics for voiding. The sympathetic trunk at the level of L2, it is going to give us the sympathetics for urinary bladder filling, and all the sympathetics and parasympathetics control the sphincters and the detrusor muscle. The male urethra is divided into the pre-prostatic, which leaves the neck of the urinary bladder, the prostatic, which passes through the prostate, and it's the one which receives the ejaculatory duct, the prostatic artericle, and the ducts from the prostate. And it's the one which can be blocked in benign prostatic hypertrophy to cause obstructive uropathy. Apart from kidney stones, even benign prostatic hypertrophy can block the flow of urine, leading to hydronephrosis. Then this is known as the urogenital diaphragm. And this urogenital diaphragm is located in that part of the perineum known as the deep perineal pouch. Inside this urogenital diaphragm, we have muscles known as the external urethral sphincters, which are skeletal, so you can control them voluntarily. These are the ones you control before you go to toilet. So that part of the urethra which is passing in between the external urethral sphincters, which are located in the urogenital diaphragm, is known as the membranous urethra, and it is the narrowest. In this urogenital diaphragm, we also have the bulbourethra, which connect to the penile urethra, and you can see the penile urethra beginning from the bulb of the penis and then the body of the penis, and it opens at the summit of the penis at the glans, and it passes through this spongy tissue, which is the corpus spongiosum. You're going to find out the length of the preprostatic urethra, the length of the prostatic urethra, the length of the membranous, and the length of the spongy urethra. Horseshoe kidney is one of the congenital anomalies of the kidneys when they are developing. The lower poles of the kidneys can come close to each other and they fuse and then they join to form a horseshoe-shaped formation. This is what we call a horseshoe-shaped kidney, and it can compress the blood vessels like the IVC and the aorta. The metanephros may fail to ascend from the pelvis in the 5th week to the abdomen, so it remains in the pelvis, and this congenital anomaly is what we call the pelvic kidneys. Polycystic kidney disease is whereby the tubules of the kidneys, they bulge and contain fluid. The kidney tubules, sometimes they are blocked, and the segments which are blocked accumulate with fluid, and then it's going to form multiple cysts. And these kidneys cannot function, so you will need a kidney transfer. The ureter can be split into two. This is what we call bifid ureter, and this is an anomaly when it was forming. But if it is canalized, it has a normal lumen, it may not create problems. It might be the pelvis splitting into two, but if the lumen is clear, it may not present with problems. The kidney tissue may split into two and cause what we call supernumerary kidneys. All these are congenital anomalies. In renal agencies, the development of the kidney is arrested at an early stage. The development of the kidney is arrested at an early stage, such that the kidney is very small, it does not develop any further, and this is also known as renal agencies. Benign prostatic hypertrophy or malignant hypertrophy is whereby the prostate enlarges, it blocks the prostatic urethra and causes obstructive uropathy, and this is what we call the benign because it's not cancerous prostatic hypertrophy.